Hello, my name is Mark Lavallee. I'm a physician based in Pennsylvania, and I'm trained in family medicine and sports medicine and orthopedics. I'm excited to talk to the Ehlers-Danlos Society meeting today on cutaneous manifestations of Ehlers-Danlos Syndrome. I've been named Bruised, Bleeding, and Broken. I want to give a shout out to Haley Yang, one of my medical students out of the University of Hawaii, for helping me with the technical side of some of the image capture of this presentation. I have no financial or business interests or just conflicts of interest or disclosures that affect this. All patients that we have pictures of have been given permission to show these pictures in this teaching slide, and kindly request that those pictures are not reproduced. There's a caution for those that may not be medically based or that are queasy or maybe under the age of 13. There will be pictures that are quite graphic in the medical nature. Just a warning. My background, as you can see here, I have classical type Ehlers-Danlos syndrome in addition to being a physician. I was diagnosed at the ripe age of 5 years old by my pediatrician. Then got to meet Victor McCusick, who holds a genetics Nobel Prize in genetics at Johns Hopkins. I joined Ehlers-Danlos National Foundation, the predecessor to the EDS Society, in 1986 as a charter member. I've worked on the Human Genome Project in 1991. Have been having EDS clinics first in South Bend, Indiana, and then subsequent clinics in Pennsylvania. I've been on the EDNF board of directors many years ago, from 2000 to 2005, and was happy to be part of the International Diagnostic Criteria Symposium in 2015, and that came out with the new criteria that came out in American Journal of Medical Genetics 2 years later. I'm currently part of the skin working group with EDS Society, and I'm part of the HEDS genetic project, partner with Dr. Norris out of Medical University of South Carolina. But today I want to hit a couple different things: brief history, interesting history, how it affected my life, with Dr. Ehlers and Ehlers-Danlos, and then get into the non-traumatic cutaneous findings, traumatic cutaneous findings, both acute and chronic, then care and interventions of acute and chronic wounds, because there's not a lot talked about that at times, skin maintenance, injury prevention, and scar treatments. Here's some older stuff from the EDS network. Is your child sitting on the sidelines? And how do we get kids with EDS, with scoliosis, with scars, with braces, active? And that's something that has been a highlight of my career and a passion in my career. So we'll just move forward. So hypoelastic dermal layers. Some of the history of this goes back to 1682. Van Merken publishes a lithograph of a Spaniard with EDS. You can see pulling his skin from his chest to his cheek, opposite cheek. Obviously, pictures in 1682. First known pictures around 1901, 1908, and this was a Dutch young man. As you can see, he's dislocating his left elbow at the same time pulling his skin. He's got some deformities of the fingers on the right hand, and of course he's got the epicantral folds in his eyes. So many very subtle features and his little pectus in that picture here on the left. The rubbermen of India, they weren't actually from India, they were from Romania, and this is a circus show act, a pedigree family from Romania that made their life in the circus. So Edvard Ehlers first published a paper in 1901, and that was a picture of Copenhagen. We'll talk more about Edvard in a bit. Here's a picture here on the left. On the right is Ehlers-Danlos, a French dermatologist who described a case 7 years later with contusions and skin laxity at a medical conference in Paris. And I have so these are where Ehlers-Danlos came from. How did this affect my life? Well, I'm a sports medicine doctor, and we had a competition in September of 2014 And we were in a little hotel and we had to walk to the venue. You can see my medical team here on the left here. And 2 blocks away was this old hospital, Amager Hospital, formerly Frederickson Hospital. This is where we walked past this every day for a week. And this is where Everard Ehlers saw the first Ehlers-Danlos patient. It's now a psych hospital. But I thought that was an amazing, that history. I walked by it every day until near the last day. I figured out where I was and the gravity. Okay, so what are some facial characteristics? When we look at each other, when you look at me and look at my face, you can see the scars and wrinkles. How do we, that's how we recognize people. One of the first things as a baby, we recognize the face of our mother, face of our father, that is someone that cares for us. So we, early on, the human brain is made to recognize the face. So what makes things unique about the skin of someone with Ehlers-Danlos syndrome? Number one is prominent scars on different places. You can see it on my face. You can see, I'm wrinkling my forehead right now. You can see the scars on my forehead from why the clumsy nature of kids, thinner, fragile skin, and you do head plants into coffee tables and other things as a child. You have hippocampal folds. This is where you have an extra sort of layer on the upper eyelid. You can touch the tip of your tongue to your nose. Blue sclera. This is one of my patients who had vascular type EDS, and you can see the high cheekbones, little wide set eyes, thin lips, and sort of a delicate nose and hollow cheeks. You can get some scarring here. This is a patient with classical type, a little scar here, a little atrophic scar. Here's the blue sclera. Here, one other patient of mine. Here's that scallop look, the wide set eyes. You can see my patient here. This is taken from literature. So the non-traumatic skin, we're going to start talking about the skin before it's hurt and injured. You can have progeria. Pro means fast, geria means aging, advanced aging, wrinkles. Okay. When you look at this picture, this is a cover of not my patient, but another patient in genetics clinic that has Ehlers-Danlos syndrome. How do you know this person has Ehlers-Danlos syndrome? Not just because his skin is all smushy, okay? There's a couple other things. Obviously, there's another person, a female hand here, but look at, this is the patient's hand. You can see the swan neck deformity of the finger, okay? So you know this person's double jointed, okay? Very subtle. And when you take the face, you can make it really wrinkly, like I'm doing right now, okay? You've got some acrogeria, okay, of the hand. This isn't a 22-year-old patient. Does not look like a 22-year-old patient. Looks more like a 70-year-old patient. And once again, we go back to the hyperelastic skin at the jaw. If we see here, we'll show other pictures of that. Here's another patient of mine who's a state champion 2 years in a row swimmer who had EDS and also had yellow-green hair. So, here he's pulling the skin out on his cheek. Here's one at the back of the palm of the hand. And then the classic elbow. The skin is very, very hyperextensible. Okay, you want to avoid pulling on places where there's scarring or mechanical forces. It's harder to assess in really young kids because of the amount of sub-Q fat that young kids naturally have. Okay, but as we age, some of us get fatter, some of us get thinner, but usually you can feel the skin separate from the adipose pinnacle. Here's another example from dermatological in Europe. Here's another example of the skin at the elbow, very thin, 20-year-old man. Here's my neck, so it's very thin. Another thing, this is Gary Turner. A lot of you have seen him on like Guinness World Book of Records. He obviously has EDS. You can see he holds couple records in Guinness World Book. One is the world's stretchiest skin. I think he has also one of he was able to place 100 clothespins on his face, pinching the skin. Not something I would recommend anybody ever trying, but he did it, and so he's in the Guinness World Book of Records. Other non-traumatic skin issues, pisogenic papules and hernias. The hernias are more of a fascial issue below, but you'll see it through the skin. Here's an infant EDS with an umbilical hernia, and also ventral hernias, which is up the linea alba. These are pisogenic papules. They're painless, generally speaking, 90% of the time. And you see them usually with weight bearing. These are outpouchings of the columnar cells in the heel pad. Okay, Another thing that's unique is you see some of these microvascular changes in an older foot. Okay, this could be a 90-year-old regular non-affected patient, or it could be a 35-year-old person with EDS. It's microvascular component. Here's something that's hard to, this is one of the few pictures we were able to find, American Journal of Medical Genetics, of a subcutaneous spheroid. These are subcutaneous, so you don't see them, but you can feel them, and they're part of the cuticular structure and organism. So here's one. I tend to take it, even ultrasounding these, they're hard to see, but you can feel, they feel like a BB under the skin. They're calcifications or hardening of the fat lobules. It usually can be after trauma, but they also can be non-traumatic. Here's another picture of the physiogenic papules, and you can see them very subtle here, down here where my pointer is, a little bit more prominent here, and here's that age-related microvascular component. So we've got two things here, and these are more with the classical type Ehlers-Danlos syndrome. We've got the chronic non-healing wounds. We hear about these commonly with our diabetic patients. And here's two different examples in two different ages. This is a 33-year-old, okay, obviously with a non-healing ulcer here. Here's a 54-year-old with a non-healing ulcer. Okay, this was non-traumatic, just sort of laying down on his knee, didn't have any pain, bruising, and this sort of developed. This was traumatic. This was a bruise that became an ulcer, okay? On the other side of the screen, over here, we got the molluscum pseudotumors. These are fleshy fibrotic nodules seen on pressure points. This is right over the second metatarsal. Was traumatic. This was non-traumatic. They can be up to 3 centimeters and look very bulbous, but they don't have an ulcer component. This one is a little slightly umbilicated, but not ulcers like these other two. These are chronic in classical EDS. Non-traumatic cutaneous stuff with hands. I've picked two pictures, one of periodontal EDS, and these are pretibial plaques. A little bit different than the pretibial scarring that you see with classical type EDS. These are more plaque-like, almost looks like psoriasis. This is dermatosporaxis, a very rare type of EDS, of the 14 different subtypes. And this is where the skin is very redundant, very thin, fragile, and easily torn. So these poor individuals always have, little bits, cuts, and scrapes everywhere. But once again, a very, very rare form of EDS. Okay, and then here's just some flexibility of the skin. Obviously, the joint is hyperflexed or hyperextended, excuse me. But the skin is also very stretchy. So, one of the things that has happened, it's happening less, but still very common. Unfortunately, child abuse is much more common than EDS. And so we have to be aware that there's probably many, many patients out there and parents of patients that have been accused of child abuse wrongly, because they show up and they have a very small story, like they just bumped into the coffee table and they have this huge bruise on their shin. Well, that doesn't look right. The stories don't always match up with what the doctor is seeing or PA seeing. This is a great example. These look like a brand new bruise, but that's permanent. That's permanent hemosiderin deposits from a bruise. So for some reason, with EDS, when you get these bruises, specifically classical type and arthrochalasia type, sometimes these bruises, they don't quite disappear afterwards. We'll show a picture of that later. Acute trauma to the skin, we'll talk about incisions, bruises, hematomas, the Lavallee lesion. It's not named, it's my same last name as me, but I did not make that freckle. And then flaps and avulsions. Here's an example of a flap. We call this a fish mouth scar, sort of looks like jaws, okay? Where you get a lot of retraction of the skin. This is a typical fish mouth as avulsion. Very, very common in the classical type, dermatosporaxis, any place where the skin is fragile, where the collagen in the skin is affected. Okay, less common in hypermobile types. This is an example of Lavallee lesion. This is your skin, your hair, fat levels. There's a shearing force. When shearing forces happen to Ehlers-Danlos patients, they either bruise or they get an avulsion. They rarely get what we call friction burns, okay, where the top layer comes off. It's either avulsing like this, and you get bleeding underneath, okay, which is different than a bruise, which is below the cuticular surface. Let's show what that looks like. So here's actually my leg after a car accident, and here is day 3. I developed this what looked like a bruise, okay, but it was very fluctuant and very superficial, not like a normal bruise in a regular unit. And so ultrasounded, and my partner stuck a needle in there and drew out 5 cc's, and this is what it looked like 21 days later. Now I wanted to show you the difference. So remember we talked about that hemosiderin deposit. Before this was the same color as this portion of my leg, Caucasian pasty white. Okay, you can see the bruising here around this, and then this was fluctuant. This is the same leg 21 days later after aspiration. You can see that there's some discoloration. That's that hemosiderin deposit that is prominent in people with classical type EDS. Okay, so that was acute. Now we're going to talk about chronic. This is cigarette paper scar tissue, we call atrophic scars. A lot of people say this looks a lot like psoriasis, okay? Or you see this over elbows, knees, and knuckles, and shins. Okay, these are all the different, it looks white and flaky and silvery and purple. Okay, in Caucasians, it's a darker color, and those with more pigment. Here's that pretibial scarring we're talking about. So let's talk about treatment of the skin issues. So we're going to talk about acute dermal issues to stop. First thing is we want to protect. If you're going to go out and play soccer, put on shin guards, wear supportive components that are going to protect your skin. Support the skin. Skin gets more redundant. People lose weight and get bariatric surgery, have extra skin, and especially with EDS, you're going to want to support that skin. Compression, whether it's using compression hose or base wraps. Stop the bleed. If someone has a big trauma, we find this in my line of work. Things bite people, pit bulls, alligators, sharks, car accidents, gunshots, unfortunately, and you have to stop the bleed. And then we want to move that person to treatment location where we can treat him definitively. So how do we treat definitively? Here's some of the things that I use in my office when I see patients with EDS, or on the sidelines, or in the emergency room. There's different types of wound closure. There's simple, I put the picture of different types of stitches because a lot of people may not know that we as physicians have particular sutures that we use, and some are better, I think, for Ehlers-Danlos than others. Specifically, talking about your skin fragile EDS types, which will be your classical dermatosparaxis, hyperplasia, and a little bit with, hypermobile sometimes, and vascular. What you see here are different sutures. My favorite is a vertical mattress suture. This is really good. It won't pull through the thin skin as much. Horizontal is another one. This one good for puckering skin and supporting it. We have simple sutures, and then of course running reticular sutures like you see above here. Other things, some kids can't tolerate stitches when they're small, so we use wound adhesives like Dermabond, crazy glue. The only difference between the two is this one's $1.50 at the Dollar General, and this is $35 medical grade, and it's got a moisturizer in it. So crazy glue you have to reapply every couple of days, and Dermabond will last about 5 days. Still need a second application. Steri strips, butterfly band-aids, and occlusive dressings are all part of how we close wounds in my office, in my practice. Other things we do to protect dermal injury is compression stockings seen below, for pads, always padding up my younger kids that want to be active. I want them to be active. I don't want them to do certain sports, but there's other sports that can, but we still need to protect them, just like wearing a helmet when you wear a bicycle ride. Some unique things we do for the hospital and health system level. Hyperbaric oxygen is extraordinarily helpful for poor wound healing. It's not just for, osteomyelitis and certain chemotherapy drugs that are overdose. There is a wound healing is very, very helpful, and there's lots of oxygen. Okay, as people age with EDS, their distal appendages, hands and feet, especially in arthroplasia, dermatosparaxis, vascular, and classical type, may have some issues with vascular, microvascular healing. Partial thickness grafts, we'll talk a little bit about that, and supportive stockings. So what are types of skin grafts that we use when we have a large wound with EDS? This is very interesting. We use full and partial thickness grafting. We have a tendency with the Ehlers-Danlos syndromes that have thin skin. Obviously, it's hard to take a partial thickness graft from someone that has hyperextensible thin skin, as I showed you earlier. But really, partial thickness is the way to go. Full thickness, what you see here, you have fat underneath that, and you have to clean all that fat off. Any place there's fat, the graft will not take. And it's also going to be thicker, and it's going to be, you wouldn't, we only use these in certain places, maybe in parts of the face for cosmetic reasons, but we'll sort of show you the difference here in a bit. So we're going to use a classical case. Patient, classical EDS, presents with necrotizing fasciitis, otherwise known as flesh-eating bacteria of the left leg. 54-year-old man presented to the ER 5 days after getting a patellar tendon rupture repair. So what ended up happening with this person? Ended up with this classical type EDS. The infection can happen to anybody. Just so happened to happen to someone with classical type EDS. So sort of a double strike. This person needed 5 debridement surgeries spaced out every 48 hours to debride the necrotic dead tissue that bacteria had eaten before the antibiotics, the triple IV antibiotics to kill the bacteria were effective. Even after it was effective, there was the subsequent surgeries. 1 reconstructive surgery using a medial gastric flap, placed an external fixator for 10 weeks, and then graft surgery at Hopkins Burn Unit, Johns Hopkins, Baltimore, because no one had ever been grafted to this extent with classical type EDS in any of the literature and known literature. So what other treatments does this patient have? Human growth hormone and testosterone, conditioned hyperbaric oxygen, treatment for 6 weeks, 2-hour sessions daily. So this is, the next pictures are a little bit on the gruesome side. So if you don't like gruesome shots, then close your eyes. So this was patient day 0. You can see this patient has Ehlers-Danlos Syndrome. Here is his non-affected leg. You can see some scarring here on the right leg, down the feet. Okay. Here is his surgical scar from 5 days previous. You can see blood, some pus coming out. And if you look carefully, right where this ellipse is, you can see some redness. This redness was advancing quite rapidly up this patient's leg. 1 day later, they had debrided it all the way up. You see no more red. You see some erythema. Still some erythema down by the leg here, but the leg was not amputated. There was a 90% chance that this patient was going to need a leg amputation. You see a wound vac and a drain, okay, but the patient still has his leg. We're now day 29. You can see after all these surgeries, he's had 5 surgeries. He's now at home after 28 days in the hospital. You can see the external fixator. So much of the tissue had been removed. There was not much holding the top of the leg to the bottom of the leg. The foot drop. So he had ACE wrap his foot with an ACE wrap to the bar, so his foot wouldn't, his Achilles wouldn't get tight. All sorts of stuff going on here. Still some drains. A lot of stuff. That black is not scar. That's the wound vac. Day 39, 10 days later, still there's no graft here. This is on the right side of your screen. You can see that this is a thin layer of biofilm placed direct over the tibia. This roundish lesion is actually the gastroc or calf muscle from his calf down here on the medial side. On the last picture on the right, you can see the scar from where they dissected out the medial gastroc and flapped it over. The real reason I want to show this to you is the next slide, which is the graft. This is the person 6 months post-op. You can see the graft site was taken from where the external fixators were in his thigh. This is up his thigh. This is right here. The area was grafted. Now you look at this. This is only, maybe 3 centimeters, and this is 16. So they meshed it. So they put little holes in it, and you can see it looks the dimpling. You can still see, but you no longer can see through the skin or the tibia. And this person is doing much better. So how do we maintain the skin so we don't have problems? We want to protect ourselves from the direct sunlight. Wear SPF 30, wear hats, wear long sleeve jacket shirts. We want to avoid long exposure or UV tanning beds. And we want to have a diet rich in antioxidants, and vitamin D and vitamin E. Remember, vitamin D and vitamin E are fat soluble, so we only want to take the RDA recommended daily amounts and not more than that, or else you have toxicity issues. Scar treatment, there's many things you can do. There's botulism toxin, medical tattooing, medical cosmetics. Here's some of the scarring that you will see in somebody with classical type, some scars, some hypertrophic, atrophic scarring, and tattooing from the hemosiderin deposits. Use Botox to help with relaxing some of the musculature underneath some scar tissue. How do we help with pain control? Skin can be very uncomfortable. So we use oral medicines, of course. Notice I don't have many narcotics here. Narcotics really should not play a role in my professional opinion, unless someone is acutely managed for pain, or they are in hospice, or they're end of life management, and post-surgical. Those are the good indications for narcotics, if you ask my opinion. Topically, you can use a lot of different things. Here's some things that I use: ketoprofen, ketamine, lidocaine, gabapentin, amitriptyline, Valium. All of these work very differently on pain. Pain from inflammation, acute pain, lidocaine is anesthetic, gabapentin is neuropathic pain, amitriptyline is chronic pain, and Valium is for muscular pain and muscle spasm. Use a lot of transdermal patches. They can be lidocaine or diclofenac. What do we do for kids? The main thing with kids have risk for skin trauma. Shin pads, knee pads, elbow pads, wrist pads. You sort of bubble wrap them, but let them go out, let them play, and you as parents have to decide how you're going to deal with what sports or activities you let your child do. Teens, you want them to have heavier heavier clothing, more elastic and impressive, supportive bras for women. All this stuff will take the tension off the skin. Adults, we want them to want to protect their hands, the skin on their hands. So wearing gloves when they're doing yard work, or some, DIY yourself stuff at home or at work. Older adults want laceless high top sneakers or boots to protect the ankles, protect their feet. We want them to do daily skin checks on the feet and ankles, because they will have some of the same issues that chronic diabetics have. Also, compressive supportive leg wear helps with venous insufficiency and some other things seen in EDS. I just want to take this time to thank you and thank my colleagues at USA Weightlifting. I put most of this lecture together in May when I was quarantined in Greece after the World Championships, quarantined in Greece with COVID before I was allowed back to the United States. So go Team USA, and thank you. The references and citations are all to follow.